Welcome to this talk, and it's always a pleasure and completely fascinating, of course, to welcome back Professor Norman Fenton. Professor, thank you very much for coming back.
Oh, it's always great to be with you, John. Really enjoy it.
We always have a great time. Now, we do have an ulterior motive today, and it's this. Professor Fenton's written a book with a fellow professor, academic Martin Neal, and it's called Fighting Goliath. And to tell you, there'll be no one else watching at the moment, Norman, so just between you and me, I didn't really understand everything in this book. There was a few bits I didn't quite get, not being a statistician as yourself. So really, what we want to do on this video is you have documented in great detail with academic specificity. It really is quite an impressive book, very, very thorough piece of academic work, and will stand the test of time as a documentation of what has occurred during these past years. But really we need to simplify it for the intelligent lay viewer. So let's kind of do that. Maybe just tell us who's Goliath in this context.
Okay, Goliath are not just the governments like the UK government and the major institutions like the Office for National Statistics and MHRA, and in America the CDC, but also institutions like the BBC and academia generally. Academia was a powerful force in promoting this fear around COVID and also in censoring any challenges to the narrative, the official narrative as we call it. That's who Goliath is. We were up against all of that, and the book documents lots of personal stories. It's not just sort of the hard scientific evidence. There are personal stories of the censorship and the letter writing, the communication between us and some of those organisations, and it kind of like shows, to a certain extent, how kind of like bizarre the whole hysteria around COVID was, but also how deceptive and at times almost sort of corrupt some of those institutions really are.
The official narrative, the controlled line that is dictated to the rest of us, and we're expected to say thank you and accept. Now, in preparation for this video, I did read first book of Samuel this morning, chapter 17, and I did notice that Goliath was a giant. He was a fighting man. He prepared for fighting since his youth, but he was slain by a shepherd boy without armour with 5 small round stones, and we believe that those round stones represent truth and scientific analysis, of course, in this context. Where would you like to start, Norman? Well, give us maybe the underlying thesis.
Okay, the underlying thesis is that there's the COVID hysteria, and that's what we call it. It was based on massively exaggerated case and mortality numbers, which were created by flawed definitions, easily manipulated data, and inaccurate mass testing of healthy people. And this led to the belief that the only way out of the pandemic and lockdowns was by this almost mandatory injection of a completely novel vaccine, which had really no real safety testing, and which turned out to be not particularly effective and not particularly safe. And the book is a sort of a complete scientific record, actually in chronological order, because, I mean, like you, John, I mean, you went through a stage where initially I'd say kind of like, I think you would admit it yourself, you were kind of like bought in to the narrative of the really, really deadly pandemic and stuff like that, and also the safety and effectiveness of vaccines. But as you saw more data, and also your own eyes, just witnessing people around you and what was happening to them, I think you came to a conclusion that this was not what was being presented by these official organisations. It maybe wasn't as deadly as was being made out, and neither were the vaccines as safe and effective as were being claimed. We also started off with a belief that maybe the science was correct that they were talking about. Maybe these PCR tests were correct, but we were looking hard at the data early on, right? And we were seeing, from our analysis of that data, a different story. So we saw that the established narrative was flawed a lot earlier than most people, including yourself. Now, I mean, I was trying to think of an analogy about this whole about this thing, that a lot of the sickness around the whole sort of COVID hysteria, it reminds me of actually when I was very young. I used to watch probably much too much science fiction on Reddit, and I was convinced, I was absolutely convinced that a horrible race of aliens from space were going to invade at any moment. And there was a particular whirling sound that I had in my head, which I believe meant the imminent landing of one of these spacecrafts. And any time at night I heard, or even imagined I heard, a whirling sound like that, I actually felt physically sick. I mean, it was a real physical emotion. I think that many people were similarly traumatised about COVID because of basically a lot of fiction that they were being told about it. I mean, the thing is that COVID was not a pandemic in the sense that that people previously defined or understood pandemics to be. I mean, something that people is not well known, and we document this in the book, incidentally, with evidence, and including letters from the head of the advisory committee on dangerous pathogens. Basically, in March 2020, I think it was on the 13th, I might be wrong about that, but I think on the 13th of March, the advisory committee on dangerous pathogens, they reached a unanimous decision that COVID was not what they classify as a high consequence infectious disease. The very next day, the UK government announced the lockdowns. I mean, it's kind of like, it's strange. I mean, do you find that weird? I'm not sure have you heard, did you know about that?
Now that you say it, I didn't actually know, not in detail, but now that you say it, it sounds perfectly preposterous. I mean, I think the thing is, and I take your point entirely, that, you know, having worked in professional healthcare all my life, I taught nurses for 27 years. We had to follow the guidelines. That was drummed into you. You know, so the guideline, I used to teach, to take an example, I used to teach resuscitation quite regularly, and every so often the Resuscitation Council would change the guidelines. And of course, you've got to update your teaching with those guidelines. So you've got this kind of habit of conformity. Now, most of the time, of course, that is a really good way to go, because these are put together by world experts in their field. I always used to teach intravenous therapy and anaphylaxis. And again, the guidelines would change to that, and you follow those guidelines, and that's basically served me well for an entire career. But things do seem to have changed now. The trust does seem to have gone. Now, of course, we're not saying this applies to everything, but it applies to many things. And you're completely 100% right, Norman. I started buying into this narrative. And I was brought up on, I've always been interested in the history of medicine. So 1348, the Black Death, the bubonic plague arrived in England. Famously 1665, the year of the Great Plague in London. And I'd taught my students for years that we are expecting another pandemic. It's a matter of when, not if. So it wasn't surprising that a pandemic came along in my lifetime. And there's a few things seem to fit together, but what is impressive is that you took the primary source data way early on in 2020, and you did the analysis yourself rather than relying on this information that the great ones on high sort of filter down to us. And myself and many others have this great feeling of being severely let down, really, this great lack of trust. But it really shows the importance of going back to the primary data and the empiricism and the primary analysis, not depending on what other people necessarily say. And that's why we're doing this. And you've done that all the way through this book. Do you feel very comfortable that your academic analysis has led to these conclusions, and that you haven't had some conclusions and looked for the academic fig leaf to cover those? Do you feel the position that you now have is emerged naturally from the empiricism in the data?
Yes, because we didn't come into it with any sort of prior conceived biases. Neither Martin nor I are virologists or epidemiologists or clinicians in any sense. We were only looking at the data and what the data was telling us. And the data was telling us something different to what the governments were telling us right from the start. And it's interesting, even before talking about the data, what you just said there about following accepted guidelines is very interesting, because what actually happened very early on, in fact, right from the start of the so-called pandemic, was that the guidelines that they've been using for years, and even the guidelines that were supposed to have been prepared for pandemics, weren't followed. I mean, just take this whole example. I'll give a very good example, is that if you just think about in terms of the data, the only real pandemic peak, where you could see a real peak in excess deaths, actually occurred right at the beginning, in March and early April of 2020. But it actually only happened, those weird peaks only happened in a number of cities, certain cities. I mean, there was Bergamo, Italy, London, New York, and a few others. And actually, in all of those places, we have come to the conclusion, from looking at all the data and looking at all of the sources. I mean, Martin has been very, 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 very rigorous in his contribution to this, came to the conclusion that most of those excess deaths there, which are of course mostly in the very elderly, were the result actually of either not following existing guidelines or following weird, strange guidelines. So, for example, at that period, they decided that they weren't going to treat bacterial pneumonia, which incidentally is what people often die of if they've got a virus, like one of these types of viruses. It's not the virus, it's the resulting bacterial pneumonia that kills them. They weren't giving people with bacterial pneumonia and COVID, they weren't giving them the normal antibiotic treatment. And of course that led to unnecessary deaths. There was inappropriate use of ventilators and these new end-of-life drugs. I mean, they were actually saying that these drugs like midazolam would never normally be given to patients with that symptomology, and yet they were giving it. So that's why we believe that what was very unnatural, it's unnatural even for a pandemic, those incredible peaks that you saw in places like London, New York, and northern Italy. We believe that was a result of the inappropriate response with these inappropriate guidelines to the virus, rather than to the virus itself. So, and then of course, following on from that, what happened was that you then had this PCR test, which was anybody testing positive was claimed to be a case, of course, and that was never a reliable diagnostic test for COVID. I mean, multiple people who were testing PCR positive didn't have a novel virus, but were classified as COVID cases. And anybody, of course, who get these definitions, which were driving the hysteria and driving the numbers that were being projected across the TV screens, every single minute of every single day, anybody dying within 28 days of a positive PCR test was classified as a COVID death. I mean, there's an analogy here, because just think about I've got sort of a thought experiment here. If you imagine that you give a large random sample of the population a token, which they have to keep with them constantly for 28 days in order to get a large reward at the end of that 28 days. Now, if they die within 28 days, we can say that they died with the token. And now, if you think about the profile of people who die with the token, it's going to be almost exclusively very old people, because it's mainly very old people who are dying at any time. And, of course, the mortality profile of people dying with COVID is almost exactly the same as you'd get with the mortality profile of dying with that COVID, with that token. There was no difference. The mortality profile of people dying with COVID was just the normal mortality profile. If anything, actually, even fewer young people were dying of COVID than other, flu-type viruses. And we've got the real data. And I think one of the things is that we've got the data from, for example, Freedom of Information requests coming from both the for England and Wales, and also from Northern Ireland. I just did an article actually this week, because we've got new stuff from Northern Ireland, thanks to Cathy Gray, so shout out to her, where we know, for example, that in the UK, in England and Wales, in the whole period, it's certainly in the first 2 years when the main COVID-defined deaths were happening, less than 5% of the people who were classified as dying from COVID or with COVID didn't have at least one existing serious comorbidity. Right? So in Northern Ireland, in the whole period, in the whole of the 4 years, we've just discovered that only 275 people in total died from what you could be classified as from COVID, or COVID even with pneumonia. Even when you add pneumonia in, there were only 275 deaths, COVID with pneumonia. There wasn't, how many people do you think under the age of 38 in Northern Ireland died from COVID?
Hopefully less than you could count on two hands. Less than
Zero. The youngest person who died from COVID, without some other comorbidity in Northern Ireland was 38 years of age. So that gives you a feel of this. I mean, the problem is that it isn't just everybody, who died within 28 days of a positive PCR test classified as a COVID death. It was the same. They were using the same classification for anyone hospitalised. In fact, it was even worse with hospitalisations, because if you'd had a positive PCR test any period 14 days before hospitalisation, irrespective of why you were being hospitalised, you were being classified as a COVID hospitalisation. And at any time, bearing in mind, they were testing everybody in hospital on entry, and every day while they were in hospital, they were testing them for COVID, right? And if they came up PCR positive at any time during their stay, they were also classified as COVID hospitalisations. Again, irrespective of what they were hospitalised for. I mean, this whole thing, I always give that joke as a bit like this whole, with being with COVID. I mean, it's a bit like Hotel California. You can check out any time you like, but you can never leave.
Quite incredible. So that data has become available in Northern Ireland. Have you got access to all the data you'd like from, take a country like the United Kingdom? Is the freedom of data? Do the authorities say that, well, there you are, Professor, analyse that for us, please? Give a peer review.
The UK, we've had a lot of run-ins with the Office for National Statistics over the last few years, I can tell you that. They are very good. I mean, they are considered to be the gold standard for data collection, and in particular medical data collection in the whole world. People look to them for the type of analysis that they do, and they do have an enormous amount of data, but it's very difficult to get what I guess people have called like the record level data that you need for doing things like determining the effectiveness and safety of the vaccines, for example.
That's the numbers you actually need to plug into your spreadsheet to get.
Yeah, and so we're reliant on the data that they're able to provide us, and they claim that they can't provide the really detailed data that we need for doing those analyses because it would breach the anonymity of people in the database. And incidentally, here's another not particularly well-known fact about the Office for National Statistics data and they were one of the only national organisations, to be fair to them, who were producing fairly detailed mortality by vaccination status data. So nominally, they were producing at least summary reports of how many people in different age groups were dying, who were never vaccinated, who had one dose, who had two doses, etc. They were producing all that data. But we could never get the data at the level to really challenge the summary conclusions that they were making. Because, I mean, for example, they were making conclusions based on the assumptions that anybody who was recorded who tested positive within 21 days of a COVID vaccination, of their first vaccination, for example, they were classified as unvaccinated. And similarly, people who died shortly after vaccination, also in most cases were classified as unvaccinated. And because of those definitions, and incidentally, all of the major studies which claimed high efficacy and safety of vaccines had those fundamental flaws and systematic biases. And what we found was that when you adjusted for those systematic flaws and biases, there was no evidence that the vaccines were effective or safe. And actually, to the contrary, increasingly, as more and more data was coming out, we were finding that when you did the adjustment in all of the in almost all of the different age groups, you were seeing slightly higher all-cause mortality in the vaccinated than in the never vaccinated. And that's, of course, is quite worrying. But the data that they were producing, was claiming something else because of these inbuilt biases.
It just shows the importance of going back to the fundamental real data.
Yeah.
We don't want to know what Joan thinks about it. We don't want to know what Harry thinks about it. We want to know what the data actually says.
Yeah.
And analyse that in a completely unbiased way. So are you open to all the data in here is all published? Are you open to peer review of all this data, and to what degree have you experienced peer review so far?
The irony about this whole thing peer review is massively overestimated. It's a massively overestimated thing. I mean, one of the things, I think I was coming to this conclusion a few years even before the whole COVID years, that academia is, being an academic myself, I was a professor in a major university, but I've been coming to the conclusion that academia is people have a massively exaggerated sense of brilliance of academia. Academia is not as great as people think it is, and peer review and the idea that, if you get a paper published in a high top level peer reviewed journal, that this is high quality science. It isn't generally. Peer review is massively overrated. In most cases, peer review is undertaken by mates of the people I mean, that's you're most likely to get it into a great journal if you're friendly with the editor of that journal, or you can recommend people to review it are going to be very sympathetic to your work. And this has always been the case. I admit to I was very, I was kind of highly ranked as an academic, and I've got hundreds of papers in journals, but a lot of the time, it was because I had very good relations with journal editors and stuff like that. So, and it's the same for everybody. And you get these little cliques of sort of scientific disciplines where actually almost nobody outside that clique is able to properly review it. So it always ends up with being people favourable to that opinion who reviews it. So that's how academic sort of peer review works. If you challenge the narrative, the established narrative in any of these disciplines, and this was the case well before COVID, of course, you wouldn't get published. You'd get ostracised from the community. And that's exactly what happened to us when we first started publishing results of our data analysis, which challenged the mainstream narrative. For the first 2 months, we weren't challenging the narrative. We were actually just publishing data which was we were doing things like we're saying, actually, we think that the mortality rate is much lower than people are saying. And that wasn't particularly considered to be a particularly uncomfortable challenge. So we had a couple of papers published in major peer-reviewed journals right at the beginning, giving that type of message. But as soon as we came in and were saying things like the entire narrative is being driven by, we think, a flawed PCR test, which is producing a disproportionate number of false positives, and that if you want to monitor the progression of this virus, you don't simply just publish the total number of cases, but you've simply got to take account of the number of people you're testing as well, and the possibility that there's false positives in here. Wow, that was it. From that moment on, we never got another paper accepted for peer review. We didn't even get them after the first couple of months after that. They were maybe reviewing it and rejecting it, always find a reason to reject it. Eventually they would never even send it to review. It would automatically be rejected. And we were even getting our papers rejected from the preprint servers, which are supposed to publish anything which is non-fraudulent. So we had a real problem getting this message out. And the sad thing about this, I mean, this is not just us, this applied to everybody who was challenging the narrative. I mean, the sad thing is, we, for example, very early on, right from January 2021, when the vaccines were, first being, when you had the mass vaccine program, we were from a very early, right from January, February there, we were looking at the early data that the ONS were publishing, and we were seeing these spikes in mortality in the different age groups, which the ONS were claiming were occurring in the unvaccinated. But the problem was, these spikes in mortality were not in COVID mortality. It was also in the non-COVID mortality. So we flagged, there was a safety signal right from the start, and we were flagging that. And oh my God, did we get, there was articles in the Times calling us mad conspiracy theorists and stuff like that. And so that message never went out. And I've spoken to vaccine injured people, people who are quite young, who never ever had any clinical need to be vaccinated. And they say that they were people who weren't given the vaccine right early on because they were too young to get the vaccine. The sort of the 30, 40-year-olds weren't getting the vaccine until about March, April. They were first being invited to vaccine in 2021, and many not until like October, until sort of August, September, October. And they were saying, they got vaccines, they were saying if they'd been aware of the kind of concerns that we'd been flagging, and about the fact that there didn't seem to be any clinical benefit in these younger people having it, they would never have taken the vaccine. So the censorship had real serious implications as far as I'm concerned.
Well, I put myself in that category. Had I known then what I know subsequently, there's no way I would have taken it from the risk-benefit analysis that we now understand.
Also, incidentally, there's something else about the evidence and looking at the evidence here. It's not just about the lethalness of the vaccine and the safety and the lethalness of COVID and the safety and effectiveness of the vaccine. Also, we looked at things, and again, there's evidence in the book here on the effectiveness of lockdowns, social distancing and masks. I mean, there's no, as far as we're concerned, there is no serious evidence that they made any difference to the progression of even of COVID cases. And as for the UK track and trace system, right, that programme, do you know that cost almost £40 billion, that programme, before it was abandoned? And there's no evidence that programme saved a single life.
40
billion pounds.
40,000
million pounds.
Yeah,
that's how much.
40 billion,
yeah. We costed that. I mean, actually, a colleague, Scott McLachlan, did a detailed costing of that, and it's been accepted. Those figures. I mean, you'll see official figures of 39 billion, and sometimes even more.
How do you imagine what a thousand billion? How do you imagine what £1,000 million is? Never mind that times 40.
Yeah, it was an unbelievable waste.
How on earth did they manage to spend that much money?
It was on all the wasted testing. I mean, you know that they had this army of people. I mean, everybody who went on any trip, remember?
Yeah.
They had to report. They had to come back, stay in their house. They had to be. There were armies of people telephoning people to make sure that they were in the house, and you had all this stuff, as well as all the massive waste of equipment that was used. I mean, it was just a total disaster. And,
and questionable procurement in some cases as well. Yeah.
I mean, the other thing that absolutely drove us crazy here was that there was this the supposed massive second wave which happened in the autumn and winter of 2020, 2021, so just before the vaccinations were rolled out. That massive second wave was basically a myth. It was just created by the fact that after the first lockdown ended in the summer of 2020, they started mass testing on a regular basis healthy people, school kids going back to school, anyone going back to work. Okay, so you had this mass increase in testing, and because of the rate of false positives, you were seeing a mass increase you're going to get a mass increase in number of cases, even though most of those were people who never had the virus, who never ill, never went on to even develop symptoms, right? But you had this mass increase. It really was. If you look at the graphs, you compare them with the supposed first real wave, which happened in March of 2020, it was like 10 times, you were getting 10, 20 times more cases in that so-called second wave. But when you looked at independent data, for example, from the 999 or the 111 service or the ambulance service, you look at all of that data relating to COVID reports and COVID symptoms, and there was nothing. There was nothing beyond the normal sort of flu-like symptom tiny wave you'd see in any kind of autumn winter season. And so the independent data, none of the independent data was supporting this idea of a serious second wave. There was no evidence of a massive increase at all in people reporting COVID-like symptoms. They just weren't.
Yeah, if you're testing 1 million people, for example, and you've got 2% false positive,
Yeah.
that's a huge number.
Exactly.
If you then go on to extrapolate that to the whole population, you get an even bigger number.
Exactly, and that's what
120 or something, yeah.
You also have another thing, is you had this thing that we report extensively in the book, and then, again, credit to my colleague Martin, because this is something that he was on very persistently and did an enormous amount of research, was the fact that the mysterious disappearance of flu in March 2020, and then its sudden reappearance at the end of 2022.
That was bizarre, wasn't it?
Exactly.
Utterly bizarre. Like 0 cases of flu for basically an entire flu season. It was,
I mean,
you couldn't make that one up. Well, people of the world, the data is here. If you disagree with Professor Fenton and Professor Neil, then there you go. Peer review it. Tell us why it's wrong. If you agree, tell us why it's right. It is there. It's a superb document. Peer review it and tell us if we're.
I'd be happy. We're always happy to take questions. Yeah.
If Norman's wrong, tell us why and how and what. Just 2 more questions, Norman. Why did all the countries of the world, according to your thesis here, make the same mistake at the same time?
A lot of it was down to those initial model predictions by Neil Ferguson and his team at Imperial College, because for some reason, I don't want to go into details of why, but even though they produced lots of massively exaggerated predictions for previous viruses, they were considered to be the go-to leading experts, and they managed to convince the government in March 2020 that there was going to be this totally uncontrollable number of people hospitalised and dying with vaccines unless you had this complete lockdown, which had never been tried before. And unfortunately, as soon as the British government accepted that, all of the other major governments, Western governments, thought they had to do the same.
Yeah. And it's strange, isn't it, that particular ideas at the moment are spreading around the world. It's almost as if there's global organisations that are in some way influencing nation states, but of course we couldn't possibly know that.
I couldn't possibly comment on that, although of course there's some interesting anecdotes. I mean, look, the book isn't just hard scientific evidence. There's lots of personal stories of both me and Martin in there. I mean, there's a personal story how early on, when I really first realised there was something maybe behind this which was not quite natural, was that I'd been on a panel which was talking about, it was how worried should we be about this pandemic? And I think it was like June of 2020. We were right hard into the lockdown, but we had this sort of beautiful weather. And there were several other academics on that panel. What shocked me was how comfortable and kind of like delighted they were with the lockdowns, because these were academics. They never suffered any of the consequences that a lot of real working people.
Well, they've probably got nice gardens, Norman.
Exactly, and not only that, but they were saying things like, we need to. They were bringing in this whole thing about the climate change narrative. They were saying, this is actually great. We need to have. This is really good for the environment because we're having these reduced carbon dioxide emissions at the moment because of the lockdowns. People weren't driving. There were no basically civilian aircraft, almost completely reduced civilian air travel. They were saying, this is fantastic. The air is so much cleaner. We need to have these sort of lockdowns on a kind of like almost a semi-permanent basis in order to combat climate change. And they, incidentally, the notion of the Great Reset, as in the sort of the World Economic Forum Klaus Schwab book named The Great Reset, which had come out right at the start of the pandemic, they were using that expression, and they were saying, this is the time for the Great Reset. And that's exactly the expression that a lot of politicians were using. Leaders of all these Western countries were using at the same time. And I was quite shocked by this. It was uncomfortable to me to hear that, because I felt, I don't believe this. And I'm worried that they believe this.
My personal preference is not to be reset. I'm quite happy the way I am. Thank you very much indeed. And I suspect that the single mum in a 2-bedroom flat with 2 kids wouldn't be very happy with the lockdown. They might have a nice garden, and my dad was in hospital for several months in that time, and last illness of his life, and we couldn't go and visit him. It's. That in itself is terrible. I think so many of those earlier deaths. I mean, these are people who are critically ill anyway, but a lot of people died early. That's in particular that peak around late March, April 2020 was because those elderly people who in many cases are reliant on the care of their close family didn't get access to that care and the psychological support.
Exactly. Yeah,
absolutely. My dad didn't die in that illness. He died the year after, but we couldn't see him for about 4 months, and
exactly. It was terrible. It's absolutely horrific.
He didn't understand. He didn't know. He didn't know. He didn't get it.
Absolutely
his mind wasn't
terrible.
as good, as sharp as it had been. And right. Very last question. What do we learn from this? What's next? What's your recommendations?
Look, I've got a few key. I'll just give a couple of key recommendations.
Yes.
Right. Yeah. One is that we should be concerned about what, like the World Health Organization and their new guidelines for the next pandemic. We should not be. We should worry about the type of authoritarian control that they want to impose on us because of that. But don't be worried about the next pandemic, because it's going. They're simply, in a sense, is it because they want this extra authoritarian control? I mean, there are people who think that, right? But don't be scared by these people. Don't they fooled us once? Don't be fooled again, because that's what I think they're preparing for. And I guess the other takeaway is a sort of this personal one. Again, I come back to academia. Don't think that academics who come up, or not just academics, but also a lot of these doctors, actually,
or authority figures in general.
These authoritative figures, exactly. Yeah. Don't believe that everything they say is true.
Don't believe anyone who says
biases,
don't believe anyone who says "shut up, sit down, and take notes."
Exactly.
I'm going to tell you the way it is.
Yeah,
it's we're not under pedagogical control.
And of course, read the book.
Oh, definitely read the book. This is a hard copy, Norman. Soft copy available? Paperback available?
The soft copy available in the UK for $19.95 and the US for $19.95. There's also Kindle ebook reader available for just $9.95 in the UK and $9.95 in the US. They get it cheaper over there because, it must be.
Yeah, they get a lot of things cheaper over there. But But there again, they have other disadvantages. So it's swings and roundabouts. So there you go, peer reviewers of the world. If you don't agree with this, we want detailed explanations of why not. And academics around the world will carry on considering and debating this. But for now, Professor Fenton, as always, been totally fascinating. I'm going to go back and look at some bits now. And it just gives me so much to think about. My head's always a bit blown at the end of these interviews. But
well, thanks a lot for giving me the time to talk about it.
No, it's been a great pleasure, as always.
Okay.
Thank you.
Thanks.